As a reminder, detailed information will be discussed regarding the decedent and this being reviewed. Although the decedent being reviewed and all information involving the situation has been completely made up, it can be distressing to some attendees to hear specific details about a suicide case and scene. Please feel free to excuse yourself from this session if you need at any time, and visit the wellness room in Morgan 3, which is right down this hallway right here. Additionally, you should have 2 documents in your folder received this morning at registration. One is a copy of the coroner's report, and the other is the toxicology report. Additionally, our volunteers should have passed out a 3rd document titled Investigator's Narrative. If you are missing any of these documents, please raise your hand, and one of our volunteers will bring you an extra copy. Before we get started, I'd like to remind everyone of the requirements of receiving continuing education credits and/or certificate of attendance. At the end of this session, I'll read out a 4-digit code, which will need to record a CE certificate for today's events. You'll have additional instructions on that. If you did not get a copy, please see us. This time, we'll allow our 9 panelists to introduce themselves.
Stakeholder table.
All right. Hi, everyone. My name is Susan Hertzfeld. I'm from Public Health Dayton, Montgomery County. I'll be facilitating the session. We're going to go through and introduce ourselves and the role we're playing, just so y'all have some context.
Hello, Austin Lucas, Program Director, Ohio Suicide Prevention Foundation. I will be playing the role of a state partner, state nonprofit. So I will be playing my real role, actually, in this session.
Hi, my name is Amanda McPeck. I work at the Zanesville-Muskingum County Health Department. I facilitate our OFR, SFR there, and today I am playing the role of the Area Agency on Aging.
Hi, I'm Megan Shabbing. I'm a psychiatrist with Ohio Health, and I'm the Medical Director of Psychiatric Emergency Services. I'm playing myself. I'm basically the token physician on the committee.
Good afternoon. My name is Steve Click. I'm the Director of First Responder Wellness for the Ohio Department of Public Safety. And much like these folks, I'm kind of playing myself. I'm representing the law enforcement component of this review.
Hello, everybody. My name is Dallas Allen. I'm the Suicide Investigation Specialist for the Franklin County Coroner's Office, and I get to play the coroner today. So I get to act a little bit bigger than I am, actually.
Hi, everyone. Leanne Watson. I'm the Executive Director at the Claremont County Mental Health and Recovery Board, and it's going to be a stretch for me today, but I am playing the Executive Director of a Mental Health and Recovery Board.
Hi, I'm Josephine Ridley, and I will be representing the VA. I'm a clinical psychologist.
And I'm Daniel Bennett, Director of Coalitions for the Ohio Suicide Prevention Foundation, and today I'm playing the role of Handsome Coalition Director.
All right. Thanks, everyone. Thank you for attending our Suicide Fatality Review Committee. I see a few new faces. I want to review our process and why we're here today. We're going to discuss one case history today and develop recommendations. We're going to start by collecting case information from all of you. I'll let you know when I have a question for you. We'll then identify gaps in services and develop recommendations for the community. I want to remind you all we're here to collaborate and improve the health of folks in our community. We're not here to place blame. We do want to identify some improvements that we can. We also want to focus on strengths in the community, see how we can make improvements. This is a confidential setting, so you may hear things in this room that we won't repeat outside of this room. So I want everyone to feel safe sharing your information, knowing it won't be shared outside of the room. I do want to go around the room since we have some new faces. We'll introduce ourselves. We already did this for you all, so it's fine. Let's go ahead and get started. We're going to review one case today. I do want to remind you all this is hard work, so step out if you need to. We want you to take care of it yourself. After the meeting, we will hang back. I'll stay on and debrief with anybody who needs to chat about what we talked about today. Some of it might be difficult. I'll be here, and I'm always here if you need to chat after that, after the meeting. So today, our case is going to be Mr. Gordon Beaumont, a white male, 72. He passed away New Year's Day, 2024, at home. His death was through a firearm. We're going to start with the coroner's office.
Thank you. I just want to talk a little bit about what I brought today. So I went ahead and brought the coroner's report. I brought the toxicology report. Then I also brought the investigator narrative. So this is what our forensic investigator found when they went to the scene and uploaded to our case. So you already gave the demographics a little bit, but the coroner's report, the external exam was completed by Dr. Nancy Smith. She went ahead and listed the immediate cause of gunshot wound of head with skull and brain injuries with a time interval of seconds. Manner was ruled as suicide. For toxicology, we could take a look at that, and we can see that for most of the illicit substances, they were not detected in Mr. Beaumont's system. There was a positive result for ethanol, continin, and then cetirizine, omeprazole, hydrocodone, and acetaminophen. Then for the basic facts, the decedent is a 72-year-old white male reported as an apparent suicide with self-inflicted gunshot wound of the head. The decedent was found by his sister, Bernadine Christie, and neighbor, Foster Landon, on January 1st, 2024 at approximately 11:15 hours, where he was unresponsive in his upstairs bedroom. Division of Fire Medic Number 1 pronounced the decedent on January 1st of 2024 at 11:23 hours with no resuscitative efforts. Mr. Beaumont was last seen alive on December 29th of 2023, but was heard from via the phone during the morning hours of January 1st, 2024. It is unknown if the decedent had any recent complaints. There was no apparent foul play or illicit drugs found on scene, but there were signs of alcohol use with multiple opened alcohol containers scattered throughout the residence. For medical history, Mr. Beaumont's medical history was reported by his sister, Bernadine Christie. Ms. Christie reported that Mr. Beaumont has struggled with chronic pain for multiple years and has most recently been experiencing gastrointestinal issues. Ms. Christie added that Mr. Beaumont received surgery in the last year on his abdomen to reduce his severe acid reflux. She mentioned that the decedent suffers from alcoholism and is also a tobacco user. It was reported by Mrs. Christie that she does not know the name of the decedent's PCP, but Mr. Beaumont was an active patient of the local VA hospital, as well as additional surgeries took place at some local hospitals that were not identified. For the scene description, the decedent is found lying on the bedroom floor of the second story of his single-family residence at 2563 September Drive, Columbus, Ohio, 43206. A firearm believed to be a Rossi M685 38 Special Revolver is located on the floor in close proximity to the decedent's right hand. There was one spent casing in the chamber with 4 live rounds. The bottom of the ammunition reads PMC 38 SPL. The firearm, shells, and casing were all collected by the Division of Police. On the first floor of the residence, an apparent note that read, "I am very ill, I'm sorry," with additional illegible information listed. A paper with bank information is located next to the note. It was reported by the decedent's sister that the decedent's U.S. Army discharge certificate was placed above the landline phone, which had never been there before. Medications found on scene include omeprazole, lisinopril, Sudafed, hydrocodone, and tramadol. The decedent is a white male with apparent gray hair, brown eyes, and natural dentition. Mr. Beaumont is found somewhat supine on the floor in his bedroom, with his shoulders and head turned to the side. He is clothed in red and black shorts and blue underwear. No property was found on the decedent. A circular defect with a blackened border observed on the right temporal region. The decedent's eyelids are swollen and purple. When the decedent was rolled onto his side, and another circular defect was noticed to the left side of the decedent's head. Rigor mortis is firm, observed in the jaw, arms, and legs. Posterior lividity is purple and fixed. Rigor mortis and livor mortis are consistent with the decedent's body position. Algor mortis is cool to the touch. A yellow identification tag inscribed 24-0000 Gordon Beaumont was affixed to the decedent's left ankle and photographed. Our investigator spoke with the decedent's sibling, Bernadine Christie, and neighbor, Foster Landon, on scene. Ms. Christie reported that her brother had struggled with alcoholism for years following the loss of his spouse in 2013. Ms. Christie also reported that due to recent physical health complications, family has begun to discuss the possibility of reaching out to local nursing homes for Mr. Beaumont. The decedent has never sought mental health treatment nor has been diagnosed with any mental health conditions. Ms. Christie mentioned that the decedent was a retired U.S. Army veteran and used to work for the city, but retired. It was confirmed that the decedent's spouse is deceased, parents are deceased, he has no kids, meaning legal next of kin is confirmed to be Bernadine Christie.
All right. Thank you. We'll go to the first responder.
Law enforcement responded to the scene at the request of the decedent's sister, checked the area. No forced entry was found at the residence. Therefore, there was no indication that anybody had entered the residence improperly. The weapon was secured. Again, it confirmed that it was a Rossi M685 38 caliber revolver, which is a 5-shot weapon. One live casing was found in the chamber. 4 live rounds were still in the weapon. The weapon was taken to the crime lab where a test slug was drawn, and that will be checked against national databases, but we do not anticipate any responses to that. The weapon did appear to belong to the decedent, although there were no registration records found with the weapon. No indication that there was any foul play involved. We concur with the investigator's narrative that this was a apparent suicide.
All right, thank you. Mental Health Board?
Just a reminder, the only information that I can obtain is through our contract treatment providers. So I did reach out to them to see if Mr. Beaumont had received any treatment services from those providers, and he had not received any treatment services, or had not received, or there had been no referrals as well. I'm not surprised by that, because typically people that are active in the VA do not typically get services in the public system, so I'm not surprised by that.
All right, thank you. How about our physician? Can you find anything?
Yeah, so I was not able to access the VA records, but based on the medical records that I did access, in the year prior to his death, he had 4 medical hospitalizations. It was noted that all 4 of those hospitalizations were related to these recurrent gastrointestinal problems that he was having, related to alcohol use and reflux. During that time, there was no mention of any kind of depression or anxiety or mental health history. There was no mention about him making any kind of suicidal comments. It was noted at times that he was irritable with staff, withdrawn at times. However, he did not at any time have a psychiatric consult or any kind of formal mental health eval. Now, of note, in the most recent hospitalization, the last one prior to his death, there was formal evaluation by a physical therapy, occupational therapy. It was thought that he was sort of on the border of meeting criteria for nursing home placement. So that was something that was at least discussed at the last hospitalization, but otherwise, as I said, no mention of any kind of mental health issues.
When was that most recent hospitalization?
That was a month prior to his death,
1
so
month
like
prior.
around late November 2023.
Thank you. All right, did anyone have any additional information? All right. What are our initial thoughts on Mr. Beaumont?
So as the VA representative, I just want to thank you for inviting me, and I am so sorry that I cannot add any specific details about this gentleman, but I do want to say that all of the factors that you guys have mentioned are very consistent with what we see in our veteran population. For example, in 2021, 72% of veteran deaths involved gunshot or firearms, compared to 52% of non-veterans. So pretty much everything you have identified for this particular veteran is very consistent with what we're seeing in veteran populations.
I think from the mental health point of view, and also the substance use point of view, there were several red flags that stood out for me. The loss of the wife, isolation, increased pain, increased health issues, the nursing home transition, stomach pain. I mean, the gastro GI issues that could have been related to, the use of alcohol. Particularly, I think the nursing home transition could have been a big trigger for Mr. Beaumont.
While she's receiving the mic, I was just going to add one more thing. 55% of the risk factors for suicide in veteran populations is pain, chronic pain. So 55% of the veterans that we reviewed through our VA behavioral health autopsy program had chronic pain. So pointing out the pain in this gentleman seems like a really significant factor.
Kind of just had a couple of questions of whether or not the sister was local or not, and his level of isolation with the chronic hospitalizations. It made me wonder if he had done any inpatient rehab or if it was all outpatient with those. For passport and things like that, it would require Medicaid eligibility, and then also on top of that, he would have to be income eligible, which is above that of the Medicaid eligibility. So those are all concerns that he might not have actually qualified for a nursing home at this point. So things to consider and to look into. I also wonder if there was a local senior center available that we could have possibly referred him to in the community.
Do we have that information on the sister? She was local.
Yeah, so I actually just, as we were speaking about that, I looked into our case because we don't have the address listed in here. So she actually lived in the state of Ohio, but not that close to him. So with the question, she was, pretty hysterical on scene. And so the information that we did get, she didn't really want to expand on much more than that. So it was difficult to get any additional information. And I also wanted to say that the bank statement information that our investigator mentioned was out. And so you spoke a little bit about the possible finances for a retirement home or nursing home. It seemed that he believed that he was in financial distress as well, just by our photograph that we had of the bank statement. So that could possibly have been an issue when thinking about placement and things like that.
Yeah, and in my review of the medical records, I didn't see anything about actually him ever going to rehab, whether it be outpatient or inpatient. Specifically, I think at the end of that last hospitalization, they wanted him to go to a nursing home. However, he didn't adamantly oppose going to a nursing home, wanted to go home to his own home, and it was determined that there was no reason to think he didn't have capacity to make that decision, so his request was honored.
So I know that the VA can't share records with us, but can you tell us a bit more about what would happen in a case like this where we have an individual who has some of these chronic pain, maybe would be a candidate for a nursing home, but maybe doesn't want to? What kind of supports would be there for them?
We do have something called home-based healthcare, where we could actually send healthcare workers to his home, including a psychologist, a social worker, of course, nurse, an RN. So we could actually provide that kind of care directly in his home. He would not have to go to a nursing home.
Thank you.
I did do a review of the computer-aided dispatch files for the local department, and there had been no calls to the residents, no calls from his sister, no issues with neighbors or any indication that he was needing any kind of social services, at least that the police department had been reported.
Was there any criminal history on him?
There's absolutely no criminal history on him. We confirmed again what we could find was that he had been a member of the United States military, but other than that we found no records. His driving record was fairly clean, just a few minor violations, nothing in the last several years.
And I forgot to mention, there was nothing in the medical record about firearms. Obviously, when we have safety plans that happen with patients who are suicidal in the hospital at any point in the hospital, typically, if there's a mention of suicidal thoughts, even passive death wishes, there would be a safety plan that would naturally entail lethal means planning. But none of that was mentioned because nothing was ever documented about him being suicidal. So no mention of firearms.
Do you know if there were any screenings at the point of care?
No, I didn't see anything for suicide specifically. There's a PHQ-9, or I should say the PHQ-2 is done on the medical units, which is a very basic depression screening. He did not trigger that. That would not necessarily, in most hospitals, trigger a psych consult, but it would at least bring to the attention of the primary team the fact that the patient had some depressive symptoms, but he did not trigger that.
I can share that in the VA system, whenever a veteran comes in, there is an annual requirement for the Columbia Suicide Severity Rating Scale. So every veteran is screened with that, no matter what reason they come into the hospital. even if it's just a regular outpatient clinic visit, pain management, it does not matter. If that screen is positive, it automatically triggers the requirement of a comprehensive suicide risk evaluation. In that CSRE, we actually do identify risk factors, protective factors, et cetera, and we do a risk stratification where we decide whether the veteran has low, intermediate, or high chronic risk and low, intermediate, or high acute risk. So if that veteran was found to be at risk at all for suicide, there would be a safety plan created immediately. And that's just our process.
Yeah, and it's interesting because in the hospitals, it's required in all the emergency departments of any of the private hospitals or non-VA facilities to screen for suicide specifically in the emergency department. However, it's not always done on the medical units if somebody's directly admitted. And in this case, it looked like he was directly admitted for his gastrointestinal problems, which is probably why the PHQ depression screening was done instead of the suicide screening.
Do we think this would be a recommendation we'd want to look towards?
Well, I mean, that's an interesting point. I was thinking along the lines of when you see all these red flags with somebody on the medical unit, I don't know that I would necessarily say we'd have to start doing suicide screening on every medical unit for every direct admit, but I think if we look at how many of these risk factors were present, and even though we never said he was suicidal, the fact that he had, older man, chronic pain, alcohol, loss of spouse wasn't extremely recent, but in the past, 7 years or 10 years, I think with the recurrent GI issues requiring hospitalization, and then kind of that final straw of the sounds like he wasn't wanting to go to a nursing home, but it was being recommended. It makes me think that if we put some parameters in place around recommending more of a mental health evaluation in a person that triggers enough of the red flags, during a medical hospitalization, again, outside of the emergency department, because I think there's a lower threshold for suicide screening, down in the ED. But so to answer your question, I think there would be an opportunity maybe for education of hospitalists where psychiatry is not necessarily involved, but maybe we look at training the hospitalists about if you have so many of these risk factors in a patient and you haven't asked mental health questions, then maybe that's something they could put into place.
I agree. I agree.
I just, something that stuck out, I know we talked about it a couple of times, but I was just reading over the investigative narrative again, and, just from my experience, I see that we had the loss of the spouse in 2013, and that in itself is a stressor and could create, mental health complications and things like that. That was never mentioned by Sister, but she did mention the increase in alcohol intake following that. She said alcoholism, but I didn't see anything of a diagnosis of alcoholism or anything. But to family's perspective, it seemed that he began to drink increasingly after that loss. And again, I don't know of any treatment for the alcoholism either, but this could have been a spot where maybe family could identify that, as an issue, and not only, and maybe it was just alcoholism that they would have attempted to look into and substance misuse treatment, things like that. But possibly if we were able to identify that alcoholism or increase in that alcohol intake as an issue, and we're able to then get him comfortable with the idea of looking into substance misuse treatment, possibly the counselor that's dealing with that substance misuse could have also identified some, mental health, or if they were possibly cross-trained, could have also dealt with the underlying mental health issues that might have led to the alcoholism with that loss. Just an idea. That was just something that stuck out to me.
Right, because he was self-medicating. Right.
And it looks like we had a indication through the physician's office that he did have alcohol use related GI conditions, so it wouldn't have just been the sister. What are some opportunities we have to connect folks to help for their alcohol use through when they're identified in that way? Do we have any ideas? I'm sorry, I think I cut you off. You were going to say something. I'd like to hear what you have.
Sure. So I was just wondering, listening to the VA kind of talk about the risk here for veterans and adding alcohol to the situation. I'm wondering if we know, was he connected to any of the social groups for veterans, like the VFW or the American Legion? And then also, potentially, if we're talking about maybe the screenings didn't capture the suicide risk there, but could that be an outreach point where we could connect with veterans and have some conversations about suicide prevention, what to look for in their peers, and also the danger that alcohol might increase that risk?
Great point.
I actually have another question along those lines. You know, I see the one firearm that was recovered, but did we also know if the decedent had any other firearms? Was he a collector? Did he have many firearms? I'm just wondering, you know, from statewide campaign perspective, you know, we have the Ohio Suicide Prevention Foundation, LifeSite Ohio, and didn't know if there were any opportunities where maybe the decedent frequented that, you know, maybe we could you know, put some campaign materials and, you know, work with the staff there, those firearms retailers. But again, that's only if, you know, I don't know if anybody has that information or not.
A cursory check of the bedroom where the decedent was found no additional firearms, no gun safe or anything. The weapon involved, small frame revolver, very typical, that would be used for home defense only. And no indication that he went target shooting or anything else like that. We did not check the full residence because there was no reason for, you know, once we had determined and the coroner's office felt it was a suicide, we really had no ability to search the house any further. The sister did not indicate that she was aware that he had a firearm.
I love the indication to pay more attention to firearms. One of the factors that we've been really studying in the VA is that we noticed when there was an increase in gun ownership and purchases between 2020 and 2021, we also noted in several of our studies that gun owners or those who purchased guns were more likely to experience thoughts of suicide than those who did not purchase firearms. And first-time firearm purchasers were much more likely to report SI or suicide ideation. So I'm really glad to hear you focus on the firearm portion.
I just wanted to add a little bit more about our investigative findings. So I was, again, looking over the cases to see any additional communication with the sister related to, you know, the circumstances, and she did not mention any of those groups that you were mentioning, but, you know, I just wanted to say I do believe that could have been a really good key piece, because if they are a part of that, a lot of times having them around like-minded individuals leading those conversations could make it easier for them to either, you know, open up or feel more apt to connect with those resources. So, again, you know, specifically VA in this situation, but also possibly even having him be interacting with more people his age. Losing his wife, you know, loneliness could have been an issue for him. Sister not living that close. And so those programs, not just for the available resources, but also connecting him with like-minded people that he can, you know, be around, communicate with, and possibly combat that loneliness.
Well, and from the coalition perspective, if he was connected in one of those groups, it's an important piece for outreach for us now with that suicide loss, because they're going to be at additional risk losing a loved one or a friend.
I do know that the Ohio Department of Public Safety's First Responder Wellness Program, when doing QPR trainings with police, fire, EMS, corrections, dispatch across the state, mentions to individuals that if you know someone that has just recently purchased a firearm, has never owned one in the past, has never wanted to be around one, buys a single handgun, normally a revolver because they're easier to use, buys one box of ammunition, no targets, no holster. All these are indications that it's probably not just strictly for home defense. And a program like LifeSite Ohio, which is training and educating our gun dealers association across the state of Ohio, is giving them an opportunity to kind of start asking questions maybe at the point of sale. If they get somebody coming in that seems very tentative or in crisis or something like that, and they're trying to make a purchase, like I said, you know, one weapon, no holster, no anything, just strictly a gun with one box of ammo. So.
Yeah, and I think we all know from the suicide risk standpoint that even if we took away all these other risk factors that are big red flags in this case, when we think about the combination, even in somebody with no mental health history, the combination of alcohol and firearm access. Those are two totally modifiable risk factors, but yet if you're not looking to do a risk assessment, then you wouldn't think about that. So to your point about alcohol screening, I think one opportunity in the hospitals, it's something that is not being required of every hospital and every space, but many of the emergency departments are doing it, some of the medical units, some of the outpatient clinics. There's been talk from the national standpoint of maybe implementing universal screening for substance use disorders at every entry point of healthcare systems. And then, you don't just want to screen, obviously, you have a system in place where whether the patient presents to the emergency department, the medical unit, the psychiatric unit, anywhere in the hospital system, substance use screening, a basic screen is done for alcohol and illicit drug use. And then if it's triggered positive, you have a substance use navigator that can intervene and just do a brief assessment and figure out what would be the best linkage for that person, whether they're going to remain outpatient or be admitted. So I think that would be a definite opportunity, and somebody even without a mental health history.
Is there any space in these conversations to talk about firearm access and safety?
Yeah, I mean, that's a good question. Again, when we think about, at least in the hospitals and in the primary care setting, that firearm discussion doesn't always automatically happen unless we're safety planning. And that's, again, something that would be triggered by somebody making a suicidal comment or saying, I wish I was dead, or, even anything along the lines of the suicidal thought spectrum.
And also, I'm not saying that this, works all the time, because there's a lot of, participation that would have to come from, friends or family. But in this situation where you have these stressing events, so think about, we're about to navigate the conversation related to nursing homes. That in itself is a life-changing event. It could be very stressful to hear. In that time, if family was, possibly knew what lockboxes were, we don't even know if they knew what those were, or had that conversation with Mr. Beaumont related to just temporary, displacement of that firearm, getting it in the possession of the sister, or just, out of the residence before they had that conversation. So not just necessarily that conversation within medical facilities, but and just increasing the education to the community about lethal means restrictions and the ways that, the different ways that you can have lockboxes, or biometric lockboxes, to where it's not necessarily a passcode, because a lot of times they might just fear that they can't have access to their firearm quickly. But if you have a biometric lockbox, it's a fingerprint, and they can still pop their firearm in the time that they needed to protect themselves, or something along those lines.
We also know that anecdotally, a lot of people, when asked that question, may deny owning a firearm. Again, Mr. Beaumont did not have a collection. He did not have, he had a handgun. There's a possibility that even if they had tried the screening at the medical facilities, he might have denied it for fear of losing that firearm that clearly was probably meant as strictly a home defense weapon up until he used it for suicide. But he may not have even been willing to be forthcoming for fear that someone would come in and take the firearm away from him.
I concur with that, because in the VA system, we have a standard screening package that happens no matter what the visit is for. Again, when they come to any clinic, anytime they're hospitalized, anytime. We screen for depression, we screen for alcohol use disorder, we screen for suicide. So there's tons of screening. In fact, our veterans complain about how much they are screened for. So sometimes they're just not going to admit. But one of the things that, what you guys were suggesting triggered an idea that perhaps we have lots of really good brochures and information about gun safety. And I'm thinking we need to leave them more in the lobbies of our ambulatory care clinics, and just have that information kind of readily there so that the veteran sees it. Have some of the signage, or post it somewhere so that they can actually see that information. That might be more helpful, because they may say no to the providers, but if they see that information, maybe that will trigger some ideas.
Is this something we could get at through those veteran social groups? So I imagine there's some talk about gun safety in general. Could we use that as a way to get at firearm safety in terms of making sure that people who are at risk may find a safer way to store their weapon?
Yeah, I think that makes a ton of sense. So we kind of talk here. It sounds like the screening's only going to happen if suicide ideation's mentioned. and they may deny even owning a firearm if we make it a universal approach. And then also to borrow from LifeSide to bring that information to them in a non-threatening way, like from a social club that they're already involved with, or a retailer they're already engaged with, as opposed to being worried that it's an attempt to take rights or access away. So I think outreach to those local social clubs makes a ton of sense.
And if I'm a first responder or veteran, I'm far more apt to surrender my weapon to a friend, to hold it temporarily, than to give it to the police department or something that makes it official, or certainly give it to my health care provider who doesn't want it, doesn't want you to come in with it or something like that. I'm a lot more apt to give it to a friend or a battle buddy and say, hey, hang on to this for me for a little bit. Or if they say, will you let me hang on to it for a little bit, I'm probably more apt to go along with that.
I was going to say something. Let me see if I can remember what it was. Couple things. Just to make sure that we got this point about making sure we remember that people that are veterans or people that are law enforcement, anybody that's been around, or hunters, anybody that's familiar with weapons, just to remember to ask them about having weapons in their homes. You know, that's a recommendation, I think, to remember to ask about having weapons in the home or having access to that. And then back to the universal screening, I think that's a recommendation as well, whether that's SFR or whatever that is. That's so important for so many reasons, you know, not just for suicide, but the whole opioid epidemic. We really should be doing that. And there was one more, but I think I might have forgotten it. Maybe it'll come back.
So I think this case is such a good example of how much we could miss some of the signs if we focus so much on screening specifically for suicide. And so I think of kind of the two buckets of opportunity here as out in the community before he ever even hit the hospital, right? And or, you know, even wasn't able to review any primary care records, but that's a great opportunity. We know most of these folks are seeing their primary care docs. For all intents and purposes, I would think that he had seen his primary care doc at least in the past few years, although he just seemed to be in the hospital more often. So in terms of the medical setting, primary care and hospital education for the hospitalists and the primary care docs and other providers about these warning signs that don't necessarily involve somebody saying, I am suicidal. And then I think to Dallas's point, looking at when somebody loses a spouse, I don't know that there's any specific age range, but especially as you've been married decades and that loss of a spouse happens, how can we, you know, best get out into the community and educate, especially when alcohol starts coming into the picture and it is a veteran who is likely to have access to firearms. You know, kind of in those two different areas, how do we provide that education?
Yeah, I think you bring up a lot of questions, and I've just been sitting here still thinking about the financial distress that he was under, and if that was a recent occurrence to him. I think bringing up the primary care provider is really great, because are they doing a social determinants of health screening there? So are we finding out if he has enough food in his house? Are we looking at his finances and if he's able to do that? That could also be a spot where we're looking at support systems there at the primary care physician, and if they had that. So if it was something with like a recent financial distress, what could we do in that terms of like helping in that manner to move that along?
That's awesome. That's a great point.
And I will say, you know, although I am the acting coroner, my professional expertise is actually in family medicine, so primary care. And so just when I took office as the coroner, that has been a big focus of just bringing primary care physicians into that conversation related to mental health and suicidal ideation, because a lot more times an individual is going to be connected with their primary care physician compared to a psychologist or someone who's trained specifically in mental illness or suicidal ideation. So being able to cross-train a little bit and have that primary care physician aware of that possibility and able to navigate that conversation, because a primary care physician, he could have had for years and been a little bit more comfortable talking about that possibly too. So just, I guess, education and training for primary care, which as coroner, it's something that I've been trying to work on as well as a lot of the colleagues that I have in that space and bring them into that conversation and help train them.
One of the things that I would want to add is this is a really good example of how complex suicide can be, because we have the immediate cause of death, which is the gunshot wound. But, you know, what triggered that could have been financial, but I really wonder if it was more the chronic pain. It says in the description of this gentleman that he was not having any relief. In fact, the suicide note says, I'm sorry, I'm very ill. The idea of going to a nursing home, losing his independence, but also going on feeling this horrible physical pain that he's in might have been enough to leave him very hopeless. So yes, he has lots of risk factors. I don't know at what point we could have necessarily intervened to make a big difference, but it seems like we need to really pay attention to chronic pain. I think that's one of those areas where we don't focus as much on the tie between the mental wellness and the physical wellness, that you just cannot separate the mind from the body. I just know that that's one of the significant risk factors. That and sleep issues are very significant and high risk factors for suicide, and we just don't pay enough attention to it. So this gentleman is very complex. Sure, if he didn't have the weapon there, he may still be alive, but that hopelessness may have driven him to get a weapon later. You know, that hopelessness from that chronic pain and the feeling that he was going to lose his independence. I think we don't want to, you know, underplay those as important.
Do we have a sense of whether the pain management for his chronic pain had some missed opportunities from looking at the records?
Yeah, it was interesting. I mean, there was mention of chronic pain, and he was on an extensive pain medication regimen. That wasn't really a big focus in the medical record. It was more, he was very upset about his gastrointestinal problems and the fact that he kept coming in over and over again, and he felt that, at least from the medical records, it looked that it wasn't getting better. So I think the chronic pain, I agree, is a huge risk factor. And it's interesting because in the hospital, I think a lot of times the focus is on, are we evaluating the pain? Are we treating the pain? And this guy, at least in the records I looked at, that wasn't his biggest complaint. He was very upset about having to come back into the hospital over and over again with these gastrointestinal problems that he felt like were not getting better. And then the fact that the last hospitalization was suggesting that he should go to a nursing home, I actually think that was, in this case, a really big factor. The combination of frustration, I'm sure, you know, in the background was the chronic pain, which already by itself would have been a huge risk factor, just as Dr. Ridley's saying. But I think in the more immediate sense, the frustration over just having to keep being hospitalized, not being able to be at home, and then being told you really should probably be in a nursing home.
Do we know how long he was in that home for? I wonder if that was the house he shared with his spouse before she passed away, if the idea of maybe leaving that setting was especially difficult as a result.
Just from looking at the narrative, it doesn't seem that the investigator had asked that question, so we're not entirely sure. But just from the photographs related to the scene, it looks like he was probably there for a while. Had a lot of things that have been there for a while, collecting dust, old items like that. So I can't give you a straight answer. We didn't get that from family, unfortunately. But we did see a lot of photos that were hung up of him and his wife, and so it is a strong possibility that they could have shared that residence together.
So thinking on the wife, he's lost her more than a decade before he passed. It sounds like he had some pretty extreme unresolved grief. I mean, grief never resolves, but knowing his history, I wonder if he ever got any support. What is available in our community to support somebody who goes through this? What would we like to see? How could we see an individual such as Mr. Beaumont, who may not seek care? How can we support him after a loss like this?
I can just touch on, I guess, just more from like personal experience, and I guess from the perspective of, when you think of a first responder or a veteran, they might be more apt to take a more of a peer approach when it comes to navigating these things and not necessarily a clinical one. And so you could think possibly of like companion groups or something like that, where he could be linked with someone who also lost a spouse, and they can actually just hang out in the community together, have those conversations that maybe he would feel then more open to having those conversations because he's meeting with someone who he knows had experienced a similar situation. And I think overall that companion could also help a lot of his stressors when it comes to that loneliness, but also having that conversation related to what is this grief, what am I feeling, and what do I do next, and being able to speak with someone who has now lost their spouse 20 years ago, and they're an example of hope. Possibly they would be more apt to be included in that instead of going to a clinician or talking about those conversations just because of his history and circumstances. Just an idea.
I like that, and kind of along those same lines. I mean, if he was involved in any type of faith, I mean, faith-based churches, that kind of thing, they have support groups. There's all other types of support groups as well, besides, because, going to counseling and that kind of thing isn't for everybody, and I'm sure the VA has all sorts of things that they could offer, support groups and that kind of thing.
One recommendation I would make, the VA does offer peer support specialists in every area, including our medical areas. So primary care has peer support assigned to each clinic. So maybe making it a little more accessible, maybe they can work on that a bit. Yeah.
So I have one question. I know you can't speak to the case individually, but this individual was diagnosed with alcohol-related GI disorder at the hospital, it sounds like. Is that something that the VA would have access to in their records so they could follow up with care coordination, or is that something they'd rely on him self-reporting?
No, they would probably assess it further and offer treatment, but of course, he may have declined.
Okay.
That could happen.
I think my question is, if he's diagnosed outside of the VA, do you get those records at the VA?
Not necessarily.
Okay.
No.
Okay.
No.
Yeah.
And
And I can tell you, unfortunately, sometimes, and it's not all the time by any means, we, at the hospital systems outside of the VA, a lot of times there's really good collaboration. I know the VA has launched some recent work that's really helped to tighten up that collaboration and make sure that these patients don't fall through the cracks. But unfortunately, there are times when a VA patient will say, I don't want the VA involved, or I don't want to go back to the VA, I want to switch systems, and then we don't have the connection and we don't have that communication between the two systems.
I know that the coordination with the VA is a different conversation. Do we think there's any room for recommendations from this group, or is that something that needs to happen at a different level?
I know that when we are aware that a veteran has received care outside of the VA, we do request the records automatically, but again, they would have to be aware of it.
Do they have to sign a release for this?
Yes.
Okay, thank you. I would like to talk about the sister. I don't know if it sounds like she didn't live close, but she was present shortly after the death. It sounds like they had a relationship. It sounds like she was aware of his alcohol use and his grief with his sister, maybe not. I don't know how well she connected those, but she was aware of both of these. What are some things that we could have provided her with prior to the death in terms of getting some support for her brother?
Well, I know that the VA has a program called Coaching into Care, and it's specifically designed for family members to help them to know how to speak to their loved one and encourage them to get help. I don't know how much we make that every client and their family aware of it. So if he was coming and she was not coming to the VA with him, she may not be aware of that offering. So I'm not sure. I don't know if anyone has any ideas around that. How can we get that information to family members who are not coming to the appointments with the veterans?
I said it's something maybe, with the groups and the social groups that we were talking about, when we were talking about putting those resources out, just messaging regarding that. So maybe this could be even something that family member would take without even their loved one knowing that they took it, and just kind of coaching themselves about that, kind of unbeknownst to the, like in this case for Mr. Beaumont, it's like take that resource and then just teaching herself that, and having those conversations with him. So maybe he didn't even know that she did that. So just increasing the access to just information related to that, because that was new to me. I actually didn't even know that was a thing. So I think if we
So to increase the public service announcements around what the VA has to offer.
yeah, so they can take the initiative to do that on their own, and have that resource and be willing to have that conversation with their loved one.
And folks up here would have much better idea of this. No matter who you go see, a dermatologist, the dentist, whatever, you're asked to provide next of kin information if something were to happen. Is it a violation then to provide that person with information just to say, hey, just in case you see something, here might be something to watch for?
Yeah, so it's all about consent. So you're right, and generally in any hospital record, there will be on the face sheet with all the patient's demographic information. If there's a legal guardian, it's on there. If not, it's the POA, right? The power of attorney. And then if there's no POA, it's usually just the emergency contact number, which is what we use as next of kin. So I think this brings up a really good point. To answer your question, no. I mean, even if there's a next of kin listed, if the patient says, no, I don't want you talking to anybody, unless it's considered an emergency, which generally only happens in the emergency room, and even then it's supposed to truly be an actual emergency, life-threatening emergency, we cannot override the confidentiality issue. But I think the opportunity here might be, especially in this case where there was no blatant comment about being suicidal or having suicidal thoughts or even having symptoms of depression, really appreciating the red flags of, that not having a spouse, even though it was a while ago that the spouse died, having the alcohol use, the chronic pain, enough of these red flags building up that maybe we provide some education to the social workers in the hospital, because they're the ones that are, when the patient allows for, that conversation to happen, that is a part of discharge planning, even outside of the psych unit or the emergency department. So in this case, had that been a part of the process, maybe the sister would have been involved and might have been aware of some of those risk factors for even depression, let alone suicide.
So this isn't necessarily related to intervening before the loss, but with the sister being out of county and speaking with the coroner's office, were we able to provide her with any resources for postvention for her own community? Are we aware of what county she was in, just as we want to work on postvention here?
Yeah, so again, we didn't necessarily have that documented on scene, and it looks like we're actually, it would be important to have our loss team here and their perspective on this. So we actually referred the sister to our loss team. Now, necessarily, they're going to be more educated on what is available here, but I would say that possibly that loss team could then navigate that process to where she was locally and help them navigate resources for just suicide loss specifically. Like I said, we referred them to loss, and then unfortunately they're not here today, so we don't know what that was, but and what if she was willing to connect in the first place. But I think that they could be the forerunner of making sure that they receive those resources in her place locally.
So thinking about this case, Dallas, you mentioned we would like to have the loss team present. Is there anyone else who should be at this table? What questions do we still have about Mr. Beaumont and his life and his passing? Are there additional people we should have? Are there things that we'd like to collect, additional data?
I mean, I would like to look at the primary care records, but I didn't have access to those. At least
And understanding that the VA won't be able to provide those. Sounds like something we'd be able to do in maybe a different case where there wasn't VA care. Any others? Do we have any other thoughts on Mr. Beaumont? Okay. I just want to remind everyone, this was a tough conversation. Please take care of yourselves. I'm going to hang on after the meeting's over. I will be sending out some draft recommendations. A few of those will be around. I'll write them out a little better, but they'll be around increasing support for veteran social groups, including firearm safety, alcohol suicide education, QPR and other services for gun shops and ranges. Looking at LifeSite Ohio, first-time firearm purchasers, additional screenings in the hospital around alcohol, around substance use, around isolation, around firearms. We know that firearm safety planning typically happens when there's been a suicide screen, but looking at additional ways we can work with our veteran support groups to look at firearm safety and expanding that and see if that's a way we can get in at some safety planning. General gun safety information at clinics at the VA and other places we might see some folks who have firearms at home. Looking at how we can support people who are possibly moving into a nursing home, including changes in prognosis, look at some safety planning or some social work referrals we can have for those folks, expanding grief for people who've lost a spouse. Some of our individuals might respond more to a companionship model or peer support, which is available through the VA. We also talked about increasing social determinants of health screening and support for folks in some of their material needs, some education for primary care providers and other providers who maybe aren't at the ED and maybe aren't mental health, but who see patients who might be able to see some of those red flags and do some screenings, providing information for caregivers, especially around some of the resources that are available from the VA if that's where their loved one might be receiving care. Also inviting the loss team and making sure that we have post-vention contacts in other areas so that we can help family members of folks who may be residing in other parts of the state. So does anyone have anything else to add? I'll get those out to you. But I thank you all for the conversation. Please make sure you take care of yourself. I'll hang out after the meeting just in case anybody wants to chat or debrief. Hope you all have a great holiday.
Okay, so we saw a meeting demonstration in progress up here. The next 30 minutes are going to be, it's 30 right? Chance for you all to ask any questions you might have about what you saw. Right? Chance for you all to ask any questions you might have about what you saw. Opportunity to ask any questions that you may have from any. Hey, thanks, Steve. This was great. I think this was great. Thank you, guys. Right. Chance for you all to ask any questions you might have about what you saw. Were there any recommendations that you thought of that weren't discussed? So on and so forth. Compare, contrast to what your county is doing. If you do sit in the Fatality Review Board, any suggestions for what you just saw here? Also, you noticed that some of the information wasn't missing, right? This was not the ideal, right? I mean, we didn't have all the answers. We didn't have all the documentation, right? And that's reality, right? So we just want to emphasize you can conduct a suicide fatality review meeting without all of the information that would make a gold star case to review, right? So don't forget that. But Any general questions? Actually, I will kick off with the first question, just to give you folks just a little bit more time to think of some. But, we just heard, Susan, you listed off a lot of recommendations there. I guess, in your experience, how do you prioritize which recommendations you implement? And obviously, you probably work with your Suicide Prevention Coalition, but I guess, how do you prioritize? Also, is the prioritization because you've reviewed other cases or you've seen similar themes? Just wanted to pick your brain there a little bit.
So I'd like to start by saying this was quite a lot of information, especially from the coroner's office and medical. When a lot of counties are starting out, when we started out, we certainly didn't have this much information. Most of our recommendations for the first few meetings were, here's additional information we'd like, here's who we'd like to invite, here's what we should ask in next of kin interview. So if it doesn't look like this for your first meeting, please don't panic. What you're doing is good, what you're doing is in the right direction. Just keep going, you'll get there. I don't implement any recommendations. I share them with the community. Any recommendation that our committee decides is worthy, that they come up with, that I want to honor their experience and that case's experience, I share that with other groups. I have a couple of coalitions locally that I share that information with, and it's up to them to kind of see if they want to move that forward. If I keep coming back with the same recommendation because we keep seeing it at repeat meetings, I'm going to put a bug in their ear and say this really is a need. What they can do, their capacity, their interests, who they have at the table may or may not allow them to work on some of that, so I let them prioritize that. But if the committee thinks it's important, I'm not going to hold it back because, I've decided it isn't. If they think it could have helped save one life, I'm gonna share that. Others might have other.
Yeah, so we kind of do ours extremely similar. Any recommendation that's created that's given to me by any team member is extremely important, and I want to make sure that that's documented, which is why in a lot of my presentations today, I kind of talked about making sure that you're asking for help, making sure that you have additional people helping you with the documentation of the recommendations so you don't miss them. And then we do work with our local coalition as well. And we're actually in the process of creating a system where we can actually categorize all of the recommendations. And so, of course, there's going to be times where a recommendation is brought up again when we're talking about like increasing education and things like that. It's going to come up again. And what we're trying to do is we're going to word that recommendation exactly like it came. But when we're then categorizing that using the socio-ecological model, we're going to then place those. We're going to still write it out. It's still going to be documented. But the idea is we're also trying to make that recommendation as actionable as possible. So we're going to make sure that we have the recommendation just as it was promoted, but then we're going to try to categorize that in a more actionable recommendation so that when we reach out to a stakeholder, we can say, hey, this is what you can do, this more digestible, actual recommendation, but in the long run, this is what it means, right? This is what every single case that when they talked about this recommendation, this is what is happening, this is what we're seeing, so that we can actually have that dual approach so that they can see what has been reported, but then maybe we would have more buy-in from the stakeholder on that more digestible, actionable recommendation, which is what we utilize the coalition to do. Them as the actionable arm is to create that system to make it easier for stakeholder buy-in.
So I know that not every community looked like this up here. So I want to ask y'all just kind of, if you want to compare and contrast, I guess, what you've seen in your community versus kind of what you witnessed up here. And again, to Susan's point, this is not, there was a lot of information up here.
I'll always try to help when we got to fill some time. I was going to kind of echo, Austin, when you asked the question and then Susan answered, is that, I sit on 4 different counties, review boards, and all of the information that you guys had up there today was great, and there's rarely a time that we have that much information. So I just wanted to reiterate to everybody that it's okay, like you said, if you don't have that much information, and I would say probably in the time you did that, some of our meetings are like done and wrapped up. So I wish we had that much information and we had that many people giving really great insight onto like the hospital system and things like that. And we were actually kind of talking at our table how we can get the right person sitting at the table so maybe we can get better interaction with some of those systems that don't always share as much. So sometimes sitting here, it's a great opportunity for us to hear what you guys are saying, because that helps us think at home where we can better represent. Maybe we have someone there from the hospital, but they're not able to speak in the way that you were able to speak up there today. So thank you for the demonstration, but also just to reiterate to other people that it doesn't always look like that, and it's okay.
So we're Zanesville-Muskam County Health Department, and I just want to share, sometimes we will just get a screen grab of a cell phone message to the coroner secretary. So that's what we'll get, kind of, hey, this is who passed away. And then we review the death certificate for additional information, which he does usually do a really good job of putting notes down at the bottom. And then we're doing all of our own investigations, so looking at the death certificate, we're looking at their obituary, we're looking at social media, we're pulling what's on there, trying to figure out what's going on from there. So we definitely don't have half this information. So.
Yeah, in Hancock County, we also don't have nearly any of that information. I really wish that I had that much information from my coroner. I am just gonna be real. They don't really come to our meetings. They are invited. Just to have the active participation would be amazing. I don't really get a narrative either usually of the scene. When it's an investigation, I only get like the cover sheet, and then I won't get the narrative until after the case is closed, and then I have to request it. So it's usually, I'm not requesting it till about a year later, and it's not, I only get like the police narrative. I don't get like descriptions of the scene. I don't get any of that. So those would all be very beneficial. And then our hospital system is present, but it's just like, it's so big, like finding the person that, I've said this in like the presentations too, finding the person that is most suitable for the committee is hard. I have someone from pain management, and then sometimes I get someone from the psychiatric unit, but like it's very hard. Like I don't get somebody from the ED. I don't, it's hard to determine what person from that agency is the right person.
Yeah, completely. And from the coroner's perspective, I know that they're not mandated to attend, but even when they are, like if there's a review happening, they are obligated to provide you with a complete report of that decedent. And so it might unfortunately be just a difficult conversation that you have to have with your coroner's office. So that narrative that I said, and they might not provide that in the complete report, because I think technically the complete report is the coroner's report, the autopsy findings, as well as the toxicology findings. And so they might not necessarily have this narrative for the review. But this should be available per every case that there was a scene response, because the investigator that went to the scene, whoever's investigating that, would have documented that scene findings, right? Because this is what the pathologist would then review for their certification of that death. And it might just be a conversation that you have with the coroner and say, hey, can we include that narrative into that, what you allow us to review for this? And again, just they might then have you, can we do an MOU or a data sharing agreement, just so I know that information is not going to be reviewed, just as a possibility to navigate that. And I do know that historically it's been difficult for coroners to be involved in this, and I do think we're going in the right direction. More coroners are here today that are in that system, and they're being a part of this conversation. So the idea is that when we continue to talk about this and show how vital their involvement is to the fatality review process, that will increase the willingness of those coroners, or and most times delegating that to someone else, just because the coroner has a lot that they're handling. And so the hope is that we'll continue to have these conversations, and we'll get more involved. And like I said, it just might be the facilitator's duty for your fatality review to just have that conversation with the coroners to see what is the barrier, why aren't they participating, and then why can't they provide this, and if they can't, is there a way to navigate around that via an MOU or data sharing agreement? That's just an idea. Might not work, but just a possibility to get just a little bit more information from the coroner's perspective. I can't necessarily speak from other health departments or hospitals locally or anything like that.
So just briefly, and then we'll make sure we get him somebody. So from the medical standpoint, I'm biased. I'm a psychiatrist in the emergency department, and I literally think about suicide every single day. I talk about it. It's my research interest, my clinical interest. So of course, I'm going to say I think ideally if you can have a psychiatrist on, or psychiatrist. I mean, psychiatrist kind of kills two birds with one stone because you have a physician, which they're recommending that you have, and then you also have a mental health professional in one. If you have a physician that's not at all affiliated with mental health, I think it'd be great if you have access to either a psychologist or a mental health professional of some sort, whether it's like my independent licensed clinical social workers, they're the ones that do the frontline assessments in the emergency department. They're really, really good. I do think having somebody mental health, from the clinical standpoint would be helpful. So if it's not a psychiatrist, having your pain management or hospitalist or primary care doc that maybe has more of an interest in mental health issues. But then if that person is totally non-mental health, having a psychologist, social worker, something like that. That would be my recommendation.
And not to, this gentleman back here, not to throw any shade to anything, but I will tell you that the coroner's office, if you're not aware, is the chief law enforcement officer in the county. So once the coroner's office has come in and they've determined in their feeling, their preliminary investigation, this is a suicide, you may not get a whole lot of interaction with local law enforcement, only because of staffing. And once the coroner's office has ruled it's a suicide, there's no criminal activity there, the law enforcement agency kind of loses jurisdiction and will probably defer to the coroner's office if they feel it's a suicide and doesn't require further investigation. They're probably going to back out, other than the initial scene, which their coroner's investigators normally do a really good job of documenting, what the weapon was, where it was located, what type of weapon it was. So if you have that opportunity, maybe they will, but please don't take offense if they don't, because in their mind, the chief law enforcement officer of the county's already ruled that this is something that doesn't require a criminal investigation.
I have a quick question. Has anybody on the panel or in the audience successfully implemented like a pool of resources that we could use? In this example, we talked about a VA being a veteran being more likely to have access to firearms and also having higher rates of suicide. Has anyone successfully implemented like a pool of resources, whether it's peers or local resources or statewide resources towards targeted populations that we could maybe review? If that makes sense. I guess I come not from public health, but my example would be we were seeing a lot of dental emergencies in the ED, which is not a true emergency that's life-threatening, but it is a frequent problem that was hitting a lot of our population. So rather than altering our entire EPIC build, what we did is we pooled resources with all of our local, and then we had a printout. So once you met that target diagnosis, you got a handout with it so you could take it and use it. Has anyone successfully implemented like a web page or a document that they're using for high-risk populations?
No, I was just going to say, we can, I can make sure to send to Austin and the planners of the convention websites you can go to for the VA. So one of the things that the VA offers is consultation, free consultation on suicide risk prevention for anyone treating veterans. And so you can call them and ask questions, or you can email them. You can even go on, reach them through social media. So we actually have lots of ways to support the community. We also have these individuals who are called CEPCs, and that's Community Engagement and Partnership Coordinators, that are, we usually have at least 2 per VA, so they should be covering the entire catchment area of Ohio. They will come to your organizations. If you want them to come to your fatality review meetings, they will. And so they are specifically embedded. They're never at the medical center. They're specifically embedded in the communities. They'll do free presentations anytime you want. So you reach out to any VA and say, I would like to have one of your CEPCs come and speak at our organization. They go to gun shows. Also, our suicide prevention coordinators will also do free presentations. They are at the medical center, but they will come. There are free gun locks. You can call any VA anywhere, and they will, get you those free gun locks. But I will make sure that you guys have the websites and the information for free consultation, et cetera. Okay.
I'm coming.
So in Hancock County, we have hancockhelps.org, and it is all of our resources, like the whole county's resources, anything you can find from food, shelter, water, recovery, treatment. The VA is connected to it, medical, there's maternal mental health, there's literally any resource that any community resource that you might need is connected to Hancock Helps, and then we have them on magnets, QR codes. So it's really like a catch-all for people to give out to anyone that, that was a question, right? What was a place to pool all the information? So we do have a website, and it is very highly promoted.
Well, and 211 as well is a great resource to collect those. I think a lot of the battle, though, is getting people to know that collection's there, and then getting them to be willing to access it when they actually need it. We struggle with that a lot, but there are some of those resources out there where things are pulled together.
I just have a recommendation for OSPF. I'm a coroner investigator for Columbiana County, and I've been doing it 12, 15 years. I've never sat through a review board. We have them, but I've never been to any of those meetings. And I would have a recommendation is to go and have this done at the Ohio Coroners Association, because seeing this, in addition to my regular coroner investigation, because if you ask me where the meat and potatoes of this, we're going to be out at 3 in the morning, and we have first row seating at this. And having seen this, I can anticipate now questions that the board might have, so I can address those at 3 in the morning and document those, because I just didn't know what kind of questions that the board would have, or the review board. So
I am really glad to hear you say that. So we've actually been working with OSCA recently, going to their regional meetings around the state. We just, it was last weekend or the weekend before, just at the Central Ohio regional meeting. Now, we didn't do a mock demonstration like what you just saw, but I definitely see that value. Again, that's why we had this. It's a whole different thing when you see it in action, right? I will definitely take that into consideration as we plan future events specifically for engaging with coroners and death investigators. So thank you.
Yeah, and I just want to add to that. I do appreciate you standing up because, personal experience, I know that you're the meat and the potatoes. I know that you're the one getting that information, and a lot of times the coroner doesn't necessarily know what's going on in scenes and stuff like that. And so if you were able to then, to tell your coroner, I would be willing to be a part of that. And it could be a possibility that they would be more apt to do that and delegate that to an investigator and let them be there, which they're the ones with the information anyway, right? You're the one that would have been doing this narrative and uploading it to the case. And so, as we have been going around and speaking with OSCA, I do believe they're being more open to the conversation, which is wonderful. But yeah, I think bringing investigators to the forefront as they're the ones that are collecting this information. You're going out in the middle of the night when these are reported, and so just your information would be extremely vital to the process. And so having more investigators knowledgeable about it as well, not just talking with coroners, but talking to the investigators, because they would be more apt to possibly be on board with that and bring that information to the table and report on their findings. So I think as we continue to do that, I think that's the idea. Bring the investigators to the forefront too and let them make the decision to be a part of the committee. So.
Yeah, Stark County. One of the things that we also kind of have, discovered is the correlation between firearm and alcohol use. And one of the recommendations that has actually moved forward, and we are working with partners in the community of alcohol distributors, putting in the bag a stuffer of crisis phone numbers, information of different resources that are in the community. And so far, it has kind of taken off and doing quite well.
Marines. United States Marines, are there? That's too bad. Their birthday was yesterday. 249 years. In May and June were the Army, the Navy, and the Coast Guard. Air Force is 1974, disregard 1947, and as you know, during President Trump, we have Space Force. Why do I bring that up? It's because of communication. You find a commonality. You're not in this for money, or you wouldn't be here. It's nice to get paid, I agree with that. But I can speak for myself, my partner, and Dr. Matthew Hintz. Money is not what we're doing this for. We're doing it as servanthood. I say that to say this. Board, do you or do you not have an agreement you have to sign that says that everything you speak about is confidential? Yes or no? Is that correct?
Yes.
Okay, out loud, please. Ladies and gentlemen, you know where the problem's at. It's communication. Find out who your coroner is. Invite him out for a hamburger. If you know where he golfs and you like to golf, run into him with a golf cart. Get to know them, build the trust. I ask for a Marine for a specific reason. We may have never met, but what was our commonality right off the bat? We went through the same stuff. Anyone else in the military? What's your branch? Army. Where at MOS?
Retired. That's what my MOS is.
Okay. What rank?
What rank? Sergeant first class.
Congratulations. What'd you do?
A lot.
I'm sorry?
A lot of stuff.
A lot of stuff. I think that was all of us. We've never met. I don't even know your name. But we've got a bond right this quick. And there's a little bit of trust there because of that bond. You're the coalition. You meet somebody that's in a coalition, you have a bond. When we go to the Coroners Association conference, there's a bond. When I first started, I made phone calls. I created friendship. When I got in trouble, I had a resource. I'm not picking on you, ma'am. The veterans, their information is top secret classified. It's like the X of all the information. That's not true. All of our veterans, if it's necessary, we get their information. It's for free. But there's a system you have to go through. And I learned that system from a Marine. I can't get it on the internet. I can't get it faxed to me. They'll mail it, but I don't ask them to. I go get it. 100 miles. I don't care. It's because I'm representing a decedent. Somebody loved this person, and I'm being paid to represent them. They've taken and they have formally, in writing, sworn an oath to keep their mouth closed outside of the meeting. The coroners can get you anything you want. They can present it to the board. They may paraphrase some things, but there's nothing they spoke of today that would violate any trust. And HIPAA is not applicable. People don't understand that either. Coordinate, get together, introduce yourself to your resources. It's the only way we're going to move forward. If we don't have a team, we might as well throw rocks in the pond. Make your connections. Start with your investigator. Get there. There's one right there. Meet your investigator. Get to know them. Build the trust. And when you have these meetings, if they can't show up, I assure you, if they're anything like our boss, even a simple suicide is 2.5 pages. We know what the inside of the refrigerator looks like. We know what the pill count is. We know what the weapons are like. We know about money in the house. We know about relatives and contacts. The last phone conversation in the scenario. What time was it and who was it? It wasn't mentioned. I'd be beating a bush to find that answer. And then compare it with, they said rigor mortis and liver mortis. Does that time match what the body tells us? There's a whole lot of information, and they were cut short, of course. The coroner people can help you. In a suicide, as mentioned, law enforcement is going to bat out of that one as soon as they can. Been there, done that. Your resource for this, for what you're doing, which is great, I applaud you. Your resource is your coroner's office. Use them, but build up trust. And I assure you, they're like preachers. To get to them, you got to feed them, and you get whatever you want. There you go.
Yeah, I just wanted to speak from a rural perspective right here. So our coroner doesn't do suicide autopsies. So we don't get, that's why I said earlier, like we get like a screenshot of a text message from someone and then information at the bottom of the death certificate is that's our narrative from that point of view. And then it must be different in our community because our coroner doesn't keep the suicide letter because that is like a public record or something. Like he explained to us that he leaves that with the police department. So our police department still is sort of involved because they keep that evidence and he sends it with them and he doesn't take anything back to his office. So I wanted to share those two things.
Yeah, looks.
The reason why the coroner doesn't keep the suicide letter is they don't have storage. They don't have secure storage. They don't have a property room. So that then, they'll make a copy of it, take a photo of it for their record, and then give it to the sheriff's office, police department, whatever jurisdiction's handling that, because they have the facilities to store that. We don't keep the gun. The statute speaks to actually the gun needs to be stored with the proper jurisdiction, and then they dispose of it later when it's no longer needed. That's why they don't keep anything.
Yeah, I mainly shared that because like you're gonna possibly have to reach out to the police department, at least in our area, we'd have to reach out to them to get an investigation report because there wouldn't be one really from the coroner. So.
I just wanted to make a side note that for Stark County, we don't do full-blown autopsy, so to speak. We do external examinations. And just from that examination and the narrative from the investigator, it gives ample amount of information to the unfortunate situation. So you don't, I guess, always need a full autopsy to discover adequate information regarding the case.
We have time for probably one more question. It's like right here, right in the front.
I would like to know how it's different I would like to know if anyone can speak to how it's different when there is a psychological autopsy investigation done and how that affects your review committee.
Well, I mean, I do similar. So I'm doing the psychosocial through the coroner's office as well. So I'm essentially an investigator, but I'm just for suicide deaths. And so I'm doing the psychosocial, which is extremely similar to the psychological autopsy. The only thing different is in a psychological autopsy, there's a root cause analysis that takes place at the end of that. And I just let that take place within my review. I do the root cause analysis together as a committee instead of actually writing that out in my own investigation. But essentially, the difference is just the amount of information available. And so we're taking a deep dive into the decedent. We're just trying to necessarily paint an in-depth picture of who the decedent was, what life experiences they had. And essentially, that's the difference. We're just identifying more information related to the decedent. And so when we're having the conversation, so like this investigator narrative, when I'm including my report, it'll be this, and then an additional 6 to sometimes I've had that are up to 10 pages of information related to the decedent. And so it's just about identifying additional shortcomings or additional factors that maybe we didn't know in here. But if I were to reach out to Bernadine Christie later and ask these questions, maybe she just wasn't ready to speak about it on the scene. But we have that during our follow-up through the coroner's office. So that would be really the only difference, is just more information.
Ditto.